my presentation was on genomic profiling and its potential impact on treatment decision. First, we know in CLL that TP53 alteration, including 17p deletion and TP53 mutation, together with IgHV unmutated status, have an adverse impact on patient outcome in the era of chemotherapy. But these factors are still important in the era of new drugs. So we have in CLL targeted therapy, including BTK inhibitor and the BCL2 inhibitor, Venetoclax. And over the last 3 years, we have multiple studies that have demonstrated that new drugs, including Ibrutinib or Ibrutinib or Venetoclax, are associated with a better PFS compared to chemoimmunotherapy. But this PFS benefit is really clear for patients with adverse genomic factor, but less clear for patients with favorable genetic markers such as mutated IgHV or normal FISH assays. So genomic profiling can help if you want to give chemoimmunotherapy. You have to check that the patient has no adverse genetic factor. And another important role of genetic factor is whether or not it can predict or can be associated with a differential response to BTK inhibition versus BCL2 inhibition. And we know, for example, that IgHV status has no impact in frontline in patients treated with Ibrutinib, while IgHV unmutated or IgHV mutated IgHV has a positive impact on PFS when patients are treated by frontline Obinutuzumab plus Venetoclax. So IgHV can be relevant for choosing between Ibrutinib or Venetoclax-based therapy, and notably the combination of Obinutuzumab and Venetoclax, that is a time-limited regimen, is a very effective combination in patients with mutated IgHV. So finally, we also have a differential impact of the TP53 mutation or 17p deletion. And for example, we know that a continuous treatment by BTK inhibitor such as Ibrutinib in the frontline setting is efficient whether the patient have a TP53 mutation or not. While in the patient treated with a frontline Obinutuzumab plus Venetoclax, the patient with TP53 alteration have a clearly shorter PFS. So this suggests that a continuous treatment with Ibrutinib is maybe a better option than a frontline treatment with a time-limited approach such as Obinutuzumab Venetoclax. So finally, we also talked about the strategy for the patient at relapse. And again, genomic features are very important, and they can help to assess the mechanisms of resistance. For example, the resistance to BTK inhibitor involve a BTK mutation, PLC gamma 2 mutation, and resistance to the BCL2 inhibitor involved BCL2 mutation, and also 1Q, that is the MC1 locus amplification. And checking whether or not the patient that was been previously exposed to one of these drugs has the resistant mutation or alteration is very important and may help for choosing or for switching the drug class in patients who presented with resistant mutation.